Friends, today we have a very important topic regarding testosterone and who actually needs to undergo hormone replacement therapy with testosterone medications. It's a sensitive topic, I filmed a lot, and it would seem, yes, such a small thing as our testicles. And there are so many questions around them, so many questions about what to do with them, who needs them, who doesn't. I've explained everything you need to know, yet there are still many questions and things taken out of context. Today's episode will teach you to understand who needs testosterone. You'll learn how to properly diagnose whether you have a testosterone deficiency or not, and you'll figure it out. You'll understand whether you really need to do this or if it just seems to you that you have low testosterone. I'll tell you what main medications are available to correct your testosterone levels and what side effects you should expect. And this episode, if you watch it until the end, will never let anyone prescribe you testosterone without proper indications. Or it might instead convince you that your life is fine and you just need more sleep. So let's begin, friends. Testosterone deficiency is an important thing. And why do I talk about testosterone deficiency so often? Why are we always talking about testosterone? To maintain normal testosterone, you must eat well, sleep enough, and exercise. You shouldn't have deficiencies or endocrine system diseases. So, in fact, when I say that I want a man to have normal testosterone, I'm talking about everything that needs to be done for that. Saying low testosterone is measured in decaliters is nonsense, but that's what happens when you discuss testosterone. This takes things out of context, even though I am a living example of how an average man should be, despite the fact that he goes to work, has a family, has hobbies and interests. To find time for yourself, to find time to invest in yourself in order to be healthy. Because when your main asset, your health, is gone, you won't be needed by anyone. There is a truth, the natural cycle of a man's life. I made a separate episode about it on my channel. We need to realize it won't always be this way. You won't always have such high testosterone levels. That's rare for anyone. That's an exception to testosterone rules. We all have a certain period in life, a peak period. For everyone, it's different. 18, 20, 23. And then gradually, we start to lower our testosterone levels. Why does it decrease? Well, simply because of aging. There are several reasons for the decrease. It's this kind of specific lifestyle, it's smoking, it's alcohol, it's also some illegal substances. None of that is beneficial. Especially the modern man. Being in such stressful conditions, obesity, poor nutrition, all of this gets worse. And in fact, under ideal conditions, you would have low testosterone at 45 or 50, but now you already have some problems at 25. This is something we need to know. We're not saying that everyone needs to start taking testosterone at 40. We're not talking about 60 either. We're talking exclusively about a specific patient. An individual approach is essential, so it's untrue that everyone over 40 or 45 needs testosterone. Testosterone is only necessary for those who, and here's the main rule, have a laboratory-confirmed deficiency. Secondly, this deficiency has clinical symptoms. And third, you have no alternative ways to fix it. Well, what does that mean? Look, the door opens. Now, a man comes in, fit, athletic, everything is fine with him. He sits down, and we check his testosterone. His testosterone is low. Low, yes. He doesn't look like it. I mean, usually what does low testosterone look like? That's a big belly. He should be sweating. He goes to the bathroom at night. He's insecure. But here comes an alpha male, and his testosterone is low. Now here's the question. I have to look at the lab results and say, my friend, you have low testosterone, so I don't care how you look, I don't care how you feel. Let's not just inject testosterone because your levels are low. That's not how it works. Let's consider the other perspective. The patient comes in overweight, all red sweating buckets. No erection, potency, or libido, just all the classic symptoms. We take a blood test, the normal testosterone level starts, for example, let's say the norm is 12 to 13 nanomoles, and he has 15. It seems normal, it seems to fall within the normal range, and I see this often during appointments. And yet he has all the symptoms. It's important to understand what is normal for a person, not just fit them into a standard and see if this causes any problems. I would never prescribe or recommend increasing, say, testosterone levels, or prescribe testosterone to a person who has no complaints. The goal of prescribing testosterone medications is to try to restore testosterone to normal levels by alternative methods. It's not about meeting others' statistics. After testing 100,000 people, we found the normal ranges as shown. It's about restoring your quality of life, my friend. So, if your testosterone is low, but you don't experience any discomfort in life at all, you don't have any symptoms of testosterone deficiency. The big question is, do you need to do anything about it? And I would say, most likely no, you don't need to do anything. But if you have a clinical testosterone deficiency, it's kind of close to normal, but you still feel like you don't have enough, then it's a double-edged sword. You might need to raise your testosterone. Why? For your lifestyle, you don't have enough. People need testosterone. Here's a good example I like to use. It's a car. Imagine two identical cars with the same power, but in the trunk of one, I throw in a bunch of cast iron radiators. And with the same power, it will have problems because the load on its system is much higher, and the power of this engine is no longer enough.
A person who pushes to the limit, even if he has all the indicators and so on, he's afraid because he knows it will always be this way. All sorts of things happen. Suddenly, he might lose the chance to get or use it, and he's afraid it's permanent. It truly is, forever. And those who are prescribed indications, well, honestly.
Good question, good question.
What percentage stay on it for life, and what percentage eventually stop? Both outcomes are fine.
Good question. Look, if we're talking about primary HYPOGONADISM, then you'll never have normal levels again. And if you were on low testosterone, you'll go back to low testosterone. If we're talking about secondary HYPOGONADISM, then testosterone medications are not needed for secondary HYPOGONADISM. So it's not good here, and it will never be good. If we're talking about people who started a cycle and chose to bulk up for summer, your question may be interpreted differently. Will they return? Will their results go back to the numbers they started with? If they went back to their natural testosterone after using testosterone drugs for many years and didn't maintain their testicular function, then honestly they probably won't return to the same numbers they had before. Is it possible that they could become permanently infertile? Honestly, I haven't seen that in my own practice. It's always possible to restore spermatogenesis. Is it possible to be on medication and still maintain fertility at the same time? Yes, it's possible. Just use gonadotropin medications together. Those scary stories about never having kids again are just myths. You will be able to... If it was low, it will remain low. If normal, there's no need to start. Because testosterone isn't about lifespan, but it is about quality of life. It's not just about toys or appearances. But I say this, and still for many people it's their profession. Some are trainers, some just made that decision. Just let it be in your life. If it does appear, let it be a well-considered step. Believe me, you don't need it. Train naturally and aim for your best without these aids. However, for some, it's a profession or a calling. And there's no other way. That I can understand. So, that's something once and for all. I understand people. As you get older, you realize you'll use it for life. Yes, I believe that you should only start taking testosterone if you understand that you're ready to stay on it for as long as necessary, not just for a month and a half or two. Now let's take another example. A typical person who works out 3 times a week and works as a broker or a taxi driver, let's say. Things are more or less okay for him. And now I say you'll do triathlon and go to the gym in the morning, afternoon, and evening 3 times a day. And at night, you'll go to a second job. And naturally, what do you think the quality of his erectile function and his overall sex life will be like after that? Well, of course, he's not a professional athlete. And this huge load, lack of sleep, and insufficient recovery will lead to him just falling apart completely. He develops hypogonadism, meaning he lacks enough testosterone for his needs. This is because, for better or worse, the man plays a lot of sports. I see this often during consultations. A person comes in and talks about feeling apathetic, all these complaints. When you look into it, you see he trains 7 times a week at 60 years old. Maybe you shouldn't be training 7 times a week at 60 years old and then saying you don't have enough energy. Train 3 times a week, you'll be fine. Don't train for 3.5 or 4 hours, train for an hour or an hour and a half, and you'll be fine. It's like having 100,000 rubles in your pocket, and your salary is also 100,000 rubles a month. A $100,000 salary sounds good. If you ask if it's enough, most people say yes. Imagine giving that to a college student. But if you have debts every month that you have to pay off, like 80,000 or 90,000, that's a different situation. So you have money, but it's not really yours. You constantly have to cover some debts, those debts that you need to pay off. That's exactly the kind of lifestyle you're living. Everything bad in your life adds to that amount of debt you have. It's alcohol, it's smoking, it's drugs, evil, it's lack of sleep. And that's why. What is a deficit? A deficit is when you don't have enough to cover everything you have. Another problem that I also encounter is that there are people who come with psychological issues. If only it were possible to just have a conversation. For example, someone might be sitting and sweating, perhaps due to being overweight, and there are various symptoms. He watched my video and, as often happens, told me, "I saw your video and have all the symptoms. I'm sure I have low testosterone. Just give me the shot." Of course, you always have to confirm it, because if you could just rely on a conversation just by looking at a young man and saying he has low testosterone, you could guess a lot of things. But making a diagnosis is never that simple. What do you think? Sometimes a person is overweight but has good hormones. Sometimes a person is thin but has low testosterone. That's why tests alone are never enough. You always need to look at the clinical picture, and clinical symptoms alone are never enough either. You always need to check with lab tests as well. That's why a deficiency is diagnosed based on what we see in lab results and on what the person feels, experiences, and tells us. And he also fills out questionnaires that comprehensively assess his quality of life. These are the Aging Males Symptoms Questionnaire, the MIF-5, and the International Prostate Symptom Score. I've shared these questionnaires before and will repost them on my Telegram channel. You'll find a link to this post below the video. These questionnaires are free for self-diagnosis, which you can simply fill out to understand whether you have any problems or not. Download and use them to stay healthy. So always examine the patient, listen to the patient, and check their lab results. And that's the only way. You need to look at it comprehensively. Because there are people who say they're fine and they're quite large, but they say everything is fine. They say they're satisfied with everything. So the assessment should also come from the patient, how they feel. It's also my independent view. How I see him, how he feels and looks, if he has a big or small belly, and what his arms are like, whether they're thin. It gets stored there. That's why diagnosing testosterone deficiency is never just about lab tests. It's never just about a physical exam. It's about a comprehensive approach. We chose the person who truly has a testosterone deficiency, and it really leads to them having certain complaints. What do we need to do? Let's figure it out. First, what tests need to be done? The tests that need to be done are total testosterone, free testosterone, and free testosterone. Not everyone checks them, because the normal ranges you see in labs are different. I consider 13 or even 15 and above to be the normal range. Using these values as the norm matches the clinical picture. It's important to check both total and free luteinizing hormone, along with follicle-stimulating hormone, luteinizing and follicle-stimulating hormones. Why luteinizing hormone? What is luteinizing hormone? Simply put, luteinizing hormone is like the gas pedal. The harder I press on luteinizing hormone, the louder and more actively my brain communicates with my testicles. Luteinizing hormone is the voice of my brain directed at my testicles. And luteinizing hormone says release testosterone, release more testosterone. I want there to be a lot of testosterone. And if luteinizing hormone is low, maybe the reason for your testosterone deficiency is that your luteinizing hormone is low. And all those methods that people use, for example, clomiphene, clotilbegit for secondary hypogonadism, are exactly for when you still have some luteinizing hormone reserve, meaning when you can still increase it. But if your luteinizing hormone is high, at the upper end of normal or above normal, then the issue is already in your head. It's talking loudly to your testicles and saying, produce testosterone, more testosterone, realizing there's a deficiency, but the testicles aren't able to provide it. This is called primary hypogonadism. That is, when we have the reserve for luteinizing hormone to rise, we can stimulate it. Or give the person chronic gonadotropin, clomiphene or clotilbegit, but with primary hypogonadism, it's always testosterone. But there is a large group of patients. This is actually the most controversial one. These are the ones who are in the middle, whose luteinizing hormone and follicle-stimulating hormone are somewhere in the middle range. It's this group of patients, since with primary and secondary everything is clear, but for those in the middle, there's always a tug of war. Those who prefer prescribing clomiphene will give it, while those who favor testosterone will prescribe that instead. That's why you need to have this knowledge in order to understand where and what options you have. Let's move on. Prolactin. Testing it is important since your testosterone could be normal while your prolactin is say 2000, and because of this you'll have problems because testosterone sensitivity gets disrupted. Prolactin itself can cause issues with potency, for example. That's why you must check prolactin to rule out benign pituitary tumors like prolactinoma. Also, sex hormone binding globulin. Sex hormone binding globulin. People may be tired of hearing about it, but you still need to check sex hormone binding globulin. Sometimes it's very high, and it's a diagnostic tool every modern doctor should use. In some patients, very high sex hormone binding globulin can cause testosterone deficiency, though not in everyone. If someone has very high sex hormone binding globulin and symptoms, high sex hormone binding globulin alone doesn't tell us much. If sex hormone binding globulin is high and symptoms match testosterone deficiency, then we dig deeper, we look at genetics, we check saliva for free testosterone fractions. If there are no complaints, nothing, even if sex hormone binding globulin is high, we leave it alone. We only treat those who have complaints. If sex hormone binding globulin is low, on the contrary, it might be a sign. Often people with low testosterone have low sex hormone binding globulin, and because of this, their free testosterone is more or less normal, but their total testosterone is deficient. Very often, sex hormone binding globulin is low in those who have low total testosterone, and because of the low sex hormone binding globulin, free testosterone becomes higher. That's why you should check both total and free testosterone. Naturally, a scrotal examination is necessary. Sometimes the testicles themselves are shriveled. Sometimes you see that luteinizing hormone and follicle-stimulating hormone are high, but there's no testosterone, the testicles. During the exam or with ultrasound, you notice signs of possible disease or trauma. They're just small. That's their entire maximum reserve. That's why a scrotal ultrasound is done to rule out primary damage. And probably densitometry, because there are things that we can realize and feel. But for example, bone density can only be measured with densitometry. Therefore, during the initial diagnosis, if we are talking about age-related, for example, androgen deficiency, or when a person has been in testosterone deficiency for a long time, it is worth measuring bone density. These are probably the basic things, plus the questionnaires I mentioned, and that will be enough for a competent specialist. Or, in the worst case, if you haven't gone anywhere, for you to understand yourself how bad or good your situation is. What should be done about testosterone injections? There are different options. Of course, there are gels, there are pellets, there are tablets, anything you want, suppositories. Even my friend came up with something that's more convenient. If there was an ideal one, I watched a video on the internet, the best testosterone for hormone replacement therapy, then everyone would be on that hormone replacement therapy. When you choose, you need to understand which medication suits you best. It's different for everyone, believe me. The same medication, one person gets bloated, another doesn't. One person has a good libido, another a bad one. First, which medication should be used? For example, someone might say they feel best using the gel. Okay, so we choose the gel. Second, how much of it do we need? The dose varies. Do you need 2 or 3 spoons of sugar? I have a sweet tooth, so 2 isn't enough. 3 or 4 is better. Same here. Everyone has their own receptor sensitivity. There is a certain number of repeats in the androgen receptor, so some people need 3 spoons of sugar, some need 4, and some need 2. And some people even say that half is enough for them. So what should you inject? How much should you inject? And third, how often? How often is usually determined by your metabolism, meaning how much you use it and how your body processes it. So all these 3 things are individual for you, and they will change throughout your life. At 25, these are one set of parameters. At 45, they're different, and at 73, they're different again. So asking how much my friend does, who is 55, or my friend who was prescribed hormone replacement therapy at 35, that's just nonsense. The main thing is to understand how it works for you and to know how to work with those numbers. And it's important to understand, by the way, if we're not talking about gel, for example, which is a medication you use every day, but about injections. You need to adjust it for yourself and remember that accumulation happens after at least 3 to 5 half-life periods. So, ideally, if you have a long injection interval, I don't recommend checking your blood testosterone levels earlier than after 3 injections. 3 at minimum, preferably 5. So after 5 injections, then you check, that will be the final number. After that, the concentration stops increasing. Even with the second injection, each one just adds to the concentration. And that's why at least 3, preferably 5, the numbers. That's a big mistake. The more the better. That's not true. Testosterone. For a testosterone injection, use the lowest dose needed for the best result. And people make a big mistake. They go on hormone replacement therapy and they stay on high-dose hormone replacement therapy. Higher testosterone is better as long as it's in the reference range. Hormone replacement therapy typically lowers sex hormone binding globulin, and the amount of free testosterone you have with this amount of testosterone, especially injectable, will be equivalent to 2 or 3 times the normal testosterone levels. So no, again, gel, cream, or injections, it's all individual. Pills probably. Pills are the biggest taboo, and no, because they affect the liver. Medications should be injectable or applied as transdermal ointments or gels. What is the effect of testosterone? You know, I've often seen people who, after watching videos, including mine, thought, well, here it is, 10 out of 10 symptoms, 10 out of 10 symptoms, they've got everything, they've got everything. They immediately start prescribing the medication to themselves. For a month, they just feel like they're flying, everything is unbelievably great, but after a month and a half or two, they end up at the psychiatrist's office. And do you know why? Yes, it's very simple. You have a psychological problem, you just have a wild, severe depression. That happens too. Just imagine, she also has low libido, apathy, lack of appetite, weakness, all of that. Sleep gets disturbed, you might start going to the bathroom at night. Very similar symptoms. A person starts using testosterone. Testosterone has a stimulating effect. He gets a boost, starts feeling a surge of energy, works harder, runs more, takes on more work. As a result, the nervous system, overwhelmed by excessive stimulation and poor recovery, deteriorates by the second or third month. In the end, the person nearly goes to a mental hospital. That's why, in reality, sometimes this first effect that you feel isn't always indicative. Many believe feeling the medication means they need it, but that's not always true. We focus on all the parameters, and that's why you should be careful when prescribing medications to yourself.
Question: does it ever happen now? Is it possible for a man aged 60, 70, or 80 to be on testosterone replacement therapy for 10 years and feel great? And he's an example of a healthy, good man in his old age. Does that ever happen?
Yes, it does. There are people who don't use anything at all because of a testosterone deficiency. If you have problems with aging, then it's probably wiser to use it rather than not use it. But that doesn't mean that if you have low testosterone, you'll have a terrible, miserable old age and everything will hurt. Pain is likely, but things might also work out for you. If everything were that absolute, if everything were that categorical, there wouldn't be so many debates about it now. This debate centers on the fact that some people feel fine without testosterone, even at 60 or 70. They have mistresses, run, play sports, and look good. And there are people who use testosterone and look terrible. They look terrible and have a huge belly. Even though they're on hormone replacement therapy is not a guarantee that you won't have a belly. Hormone replacement therapy is not a guarantee of good quality of life. The foundation is always the guarantee. It's about your routine and how you invest your time in yourself. And there's a question, a common one. Should a doctor look good? Yes, I've heard that. Especially if they're treating hormones, should they look good? Shouldn't they look good? Can he be a good specialist and still have a big belly? He may be overweight and have a big belly, yet still know hormones better than anyone. Do I agree? No. Why? Because it's a matter of values. It's a matter of values, and if I share these values and am honest with myself, then I shouldn't have a big belly. I should try to fix it. I should be an example. That's why I have colleagues who are on a diet and on hormone replacement therapy, and at the same time they have quite a big belly and they don't lead a very healthy lifestyle. We, as doctors, if you've chosen this profession, we should be an example and heal not only with words, but also with our own example and actions. If I came to see a dentist who didn't have a single tooth in his mouth, of course, he might be the best dentist, but I would feel more comfortable being treated by someone who shares the same values as I do. Is it possible not to be on citrone with secondary hypogonadism? Of course it is. There are drugs that stimulate. Testosterone production involves urinary gonadotropin, also known as classic chorionic gonadotropin, which is obtained from urine. There are recombinant synthetic medications, for example, avitroel, And if they help, if they work, they can eliminate the need for you to take testosterone. So you stimulate the production of testosterone rather than replacing it. But if its primary hypogonadism and your luteinizing hormone and follicle stimulating hormone are very high, this won't work. So it only works when luteinizing hormone and follicle stimulating hormone are in the middle or low. Medications include Chircas, Clomid, Clostobegit, and anastrozole. Of all these medications, the only one I can likely use in practice is Clomid. I'm not a big fan of medications that lower the level of female sex hormones because in the long run, that's not very good for the vascular endothelium. So if I had to choose among all of them, the drug of choice would probably be Clomid, clomiphene citrate, but not anastrozole. What else needs to be done? What needs to be done? Well, you need to understand that there are necessary measures you should know and keep in mind if you are using testosterone drugs, because side effects are possible. What kind? I wrote them down. Suppression of sperm production and reduced fertility. If you still want children, use gonadotropin in some protocols. For example, that's 1,000 to 1,500 per week until you need to have a child. When you have this need in a more active format, you start adding medications, or you start doing it twice a week, and you also add additional medications. Acne, oily skin, remember puberty? Breakouts. Why? High testosterone causes acne to appear quickly. Fluid retention and increased blood pressure are common with testosterone medications. The extent varies by individual. Some experience more, others less. That's exactly why bodybuilder athletes often stop taking testosterone medications before going on stage, because the body retains fluid. If you have hypertension, you need to take this into account. Increased hematocrit raises the risk of thrombosis. Yes, there are people whose blood thickens and there are people whose blood doesn't thicken, and unfortunately this also needs to be considered. Gynecomastia is breast enlargement. Yes, it can happen if you don't control your estradiol and prolactin levels. If your prolactin and estradiol are high, because of these two hormones, you can develop gynecomastia. That means female-like breasts. It will be female-like breasts, and then you'll have to get surgery. The lipid profile can be affected. Yes, but as they say, it's a 50-50 chance. For some people it gets worse, for others it gets better. Paradoxically, there are contraindications to hormone replacement therapy. There are contraindications, and most often these are hematological issues or problems in oncology patients. So, if there are precancerous conditions, for example, regarding prostate cancer, let's say we already have a condition where we suspect prostate cancer, you can't, since prostate cancer uses testosterone as fuel. There was a scientist named Higgins. He received the Nobel Prize because he discovered a long time ago that there are people who already have prostate cancer. And if they undergo castration, have their testicles removed, and their testosterone drops to zero, they live longer and the tumors start to shrink. And then he proved that there are hormone-dependent tumors, and these include testosterone and prostate adenocarcinoma. Many people, especially colleagues, thought that when he won the Nobel Prize, it meant testosterone causes cancer, specifically that testosterone leads to prostate cancer. Actually, no, and it's a paradox, but testosterone deficiency increases the risk of developing an aggressive form of cancer. So if we take two groups of patients, one with good testosterone levels throughout their lives and the other with very low levels, the cancer that develops in a patient with already low testosterone will be more aggressive, and very often the tumor markers will be lower. Therefore, when a person faces the question of whether to prescribe hormone therapy or not, a very important criterion is that if there is no cancer, then it can be prescribed. Now, with modern methods, for example, prostate removal allows us, if the cancer has been defeated, even for a patient who had prostate cancer, to prescribe testosterone medications. But the older generation of doctors is still very cautious. If hormone therapy is not indicated, how can testosterone levels be maintained naturally? A full night's sleep of 7 to 8 hours is important, as regularly losing 1-2 hours may age you hormonally by 10 years. Physical activity, regular strength training, workouts, yes, but not too much, because too many workouts will deplete your testosterone. You must find the golden balance in healthy nutrition. Yes, more protein, more vegetables, omega-3 fatty acids, definitely. Zinc must be included in your diet. Weight control and loss, absolutely. The more fat you have, the more testosterone will convert into female sex hormones, and the worse it will be. Losing weight is the key to restoring normal testosterone levels. And the fifth point is to avoid chronic stress. Should I just move to the woods or something? Yes, the more stress and pressure you face, the more testosterone you need to compensate. And yes, that's really how it works. But you need to understand that you often go to the doctor expecting him to solve everything for you. That's not how it works. You shouldn't try to fix your life with some kind of testosterone shot. It's just an aid and only in cases where there's no other way. Let's sum up, and I'll remind you once again. Testosterone is only needed where there is a deficiency, and this deficiency leads to clinical symptoms that are directly related to the deficiency itself. Because many conditions have symptoms that look very similar, like masks, but they are not actually caused by low testosterone. So a person may have low testosterone, they have low libido, and laboratory tests confirm low testosterone. It all seems to add up, but his problems are actually psychological. That happens. Having testosterone deficiency with clinical signs doesn't always guarantee certainty. That's why you can't and shouldn't think in absolutes here. And third, there shouldn't be any contraindications related to the blood coagulation system or certain risks. There should be no alternatives, meaning in cases of primary hypogonadism, when there are no alternatives. In all other cases, you have to weigh the options. Because it's possible to correct this through lifestyle changes, exercise, lose weight, reduce stress levels, get more sleep, and compensate for any deficiencies that are present. And if you've done all that and there's still no other way, and therapy with gonadotropins or clomids doesn't help. Yes, if there are indications and no contraindications. Even then, I think you always have to weigh it. If it only improves the quality of life by 10%, it's not worth it. Probably we should see a bigger, more noticeable difference. And hormone replacement therapy actually, as many of you for some reason think, is about prolonging youth and extending life. In reality, people on hormone replacement therapy actually age visually faster. That's one thing. Secondly, hormone replacement therapy is not about lifespan, it's about quality of life. And there is a huge amount of evidence for this. These are historical castrates. Eunuchs who lived as long as others but looked and lived differently. And there is plenty of evidence that people live just as long. They just live differently and get less pleasure. And that's why when you are faced with this question, should you do something or not? Here is the scale. All you need to do is put all the pros you'll get on one side and all the cons, which are quite a few, on the other, and weigh them. Should you do it or not? Doctors actually often like to make this decision for you, but this decision should be made together. Together, you need to weigh all the pros and cons. I hope this episode, which you watched to the end, was useful and helps you make the right choice. Maybe try sports or change your routine. Sometimes let go of what's unnecessary and avoid shortcuts. Because our inner laziness often pushes us to choose the easy way. Not to change your lifestyle, but just to get an injection instead. Stay healthy, take care, and I wish you a long life. Thank you.